Okay, so hello everyone. My name is Jessica Katanga, final year medic. Oh, you can't see me. Hold on, let me just put my start video. Hello everyone. My name is Jessica Katanga, final year medic, as Savannah already said, a YouTuber and aspiring neurologist with interests in public health. I've been asked today to kick off their Redefining practice series, so thank you. And today I've decided to focus on disability and race. So thank you all so much for joining this lecture. I know we have people from health backgrounds, non-health backgrounds, so hopefully today's session will be interesting and interactive. And if you have any questions, just write them in the chat and then maybe we'll look at them at the end, or any comments as well, not just questions. Yeah, so let's begin. Okay, so I'll start with the definition and prevalence of disability before we go into the aims of the, so how do I, okay, next. So disability, the definition, as defined in the Equality Act 2010, a physical or mental health condition that has a substantial and long-term adverse effect on your ability to do normal daily activities. So it can be visible or invisible. And how many people do we think live with disability around the world? So I've put some options here. If you could maybe write in the chat your answers, A, B, C, or D. I'll give you some time to do that. Anybody? Yeah, okay, so you've had time to think. So it's actually, the WHO estimates that over 1 billion people are living with some sort of disability worldwide. So that's 15%. And in the UK, this is 11 million people. The prevalence of disability increases with age. So as we go from children to adult to pensioners, it goes from 6%, 16%, then 45%. The most common disabilities in adult age are to do with mobility and lifting, but for children, it's cognitive impairments. Now, I feel like that was extremely high and I had no idea. And one reason for that disabled people say is the erasure of people with disabilities from the media. So can anybody give me examples, or maybe if you think to yourself, examples of some celebrities that have a disability? So it might be quite difficult. And a quick Google search of celebrities with disabilities, we see a very homogeneous list. So people with disabilities are an underrepresented group, and disabled people of color more so. And this was the message behind the hashtag #DisabilityToWhite a few years ago. So here are some examples of famous and non-famous disabled people of color. And then now some statistics. So in the USA, disability rates are higher in the Black community, with 1 in 4 African Americans compared to 1 in 5 white Americans. In the UK census, Pakistanis and Bangladeshis reported the highest rates of disability, at 1.5 times higher than white counterparts. And Black British disabled people reported more life areas where they felt restricted, and white disabled people reported the least life areas affected by their disability. And I'm sure some of these celebrities might or might not be a shock to you, but this just further highlights the fact that disabilities can be invisible, and we'll talk later on about how that can be a catch-22 for disabled people of color. In general, this is what we'll discuss today. The unique barriers people with disability face, how these barriers are compounded for BAME disabled people, so that's Black and minority ethnic, what ableism is and how we can reduce it, solutions, so how we can redefine practice, as this series is called, and advocate for our patients living with disabilities. And as I said, any questions that you have along the way, feel free to write them in the chat and then we can discuss them at the end. So, barriers. So, and all my statistics are for the UK unless I state otherwise. So poverty, when there is a disabled member in the household, that household is more likely to be in poverty, 19% compared to the nationwide 15%. This is due to the inequality in employment. In 2012, the Labour Force survey showed 46% of working age disabled people are employed compared to 76% of working age non-disabled people. So that's a gap of 31%, and that represents over 2 million people. Whilst at work, they're more likely to receive discrimination, which ties into the education attainment gaps, as disabled people are 3 times less likely to hold post-19 qualifications. So that's qualifications after sixth form or college. And whilst at school, they may be at higher risk of being bullied, and they are more likely to be underestimated by their teachers and therefore not reach their full potential. According to the Equal Rights Centre, people who are disabled are at higher risk of domestic violence, sexual assault, and abuse. The red flags for abuse are the same as for non-disabled people, but there are additional things that we should consider, such as carers mixing medicines, carers not taking them to their appointments, family members misusing their disability benefits, and more. And so, which of these factors are compounded by race? Yep, you guessed it, all of them, and more. So there are worse rates of unemployment and worse rates of poverty. So that's 40% of working age BME disabled people are in unemployment compared to the 6% I stated earlier. And half of BAME disabled households are living in poverty compared to the 19% I stated earlier. As well as disability discrimination, disabled people of color have to face racial discrimination and bullying too, in workplaces, in schools, and in hospitals, which we will unpack in a minute. And in terms of abuse, well, back to the USA, police brutality is an everyday fear for African Americans. And of the vast swathes of people killed by the police, 1/3 to 1/2 of those are estimated to have disabilities. So some famous examples: Sandra Bland had epilepsy, Freddie Gray had learning disabilities, and some are deaf, so could never hear the orders in the first place. In this Guardian article where I got this image from, it quotes Deborah Danner, a 66-year-old woman who was living with schizophrenia. She had written an essay on mental disability stigma, where she said, we all know of the all too often occurrence where the mentally ill come up against law enforcement and instead of receiving medical attention, end up dead. Unfortunately, 4 years later, her fears became true when her neighbor called for help as she was behaving erratically, and the New York Police Department showed up instead and shot and killed her. In the UK, where police can use tasers and truncheons, these can and do result in seizures, cardiac arrhythmias, or permanent disability. Furthermore, police are not trained in epilepsy, so epileptic seizing can be mistaken as non-compliance. Restraint is then used, which is, of course, extremely dangerous during a seizure. And in the UK, those with borderline learning disabilities are represented highly in HM prison system. So now I'm going to talk about the next barrier, which is access to medical services. So you see how, even though this is a health lecture, we've had to explore the problems our disabled patients of color face well before they even step into our clinic rooms. The patient's outside life makes up the bulk of their health and well-being and greatly impacts the efficacy of any interventions we prescribe or put in place. So we must always be cognizant of that. So in the USA, there was a study of around 280,000 participants. We see that for the most popular neurological outpatient diseases or disabilities, so MS, which is multiple sclerosis, epilepsy, Parkinson's, and stroke, Black patients were 30% less likely to have outpatient visits, and this was even after accommodating for health insurance. In the southeast of USA, there's a strip of land called the Stroke Belt, so called as it has the highest incidence of cerebrovascular disease, that's a brain vessel disease. It also has a very high African American population. Despite the highest incidence of brain and heart disease, it has drastically fewer neurologists per capita compared to the Northeast. Neurologist involvement in these long-term disabilities is key as it reduces A&E visits, adverse outcomes, and improves quality of life by managing people's symptoms. We know that neurological diseases are often chronic And so engagement with services is something we need to be making sure is equally distributed so that all our disabled patients can have improved quality of life. Now, once our patients have accessed services, we have to also consider service engagement. In a UK survey in 2008, 32% of disabled people reported experiencing difficulty accessing the items or services needed relating to their impairment. And this is worse for Black and ethnic minority disabled people because of social and cultural factors. So these points on the slide, I couldn't list them one by one because really they're more of a web, and I'll just go into them more now. So data shows that Pakistani, Bangladeshi, and Black African individuals in the UK are least likely to be in receipt of the DLA, that's the Disability Living Allowance, i.e. the disability benefits. And it seems lack of information might be the reason. So firstly, the websites, leaflets, or social workers that tell the patients what they're entitled to, are they accessible to patients who might speak Bengali, Arabic, Somali, etc., all quite popular languages in the UK? And then for deaf or hard of hearing people, of which 1 in 6 Brits are, how many deaf-friendly, i.e. signing social workers and healthcare professionals are there? So Christiana Adenrele, 20-year-old Black British deaf woman, wrote, "Recently, I went to the doctors in central Milton Keynes about my back. Not long into their appointment, I had to inform her that I was deaf. I presume she already knew based on my medical profile. She spoke to me while she looked at her computer and I couldn't understand her at all. She appeared frustrated and annoyed at my request that she face me when talking so that I could lip read. It's those moments when I feel horrible about myself and I feel guilty. She started to rudely wide-mouth questions at me and patronize me in ways that made me feel uncomfortable and upset. She sent me on my way visibly relieved. But what if I had missed vital information on my back or misinterpreted a medical suggestion?" A disabled Asian woman who looks after her disabled husband said, "When you ask for information, you are treated as if you are trying to get something you're not supposed to have." Another focus group revealed that stigma in their community around disability was a deterrent to them accessing services because they were trying to keep their family members' disability a secret. Now, of course, when we say BAME, that refers to a lot of cultures, but there are some trends in these cultures, and one of them, in some of the cultures, disability is still very much taboo, with some thinking that disability might be a curse or bad luck or a sign of inferiority, which then shows why they feel like it should be a secret. Some research has also found that BAME disabled people can also be less likely to use a service if they do not see people, either the workers or the other users of the service, that look like them. So this shows that representation in healthcare matters. So what can we do to make our society and practices less ableist? So the definition of ableism is a set of practices and beliefs that assign inferior value to those with physical, psychiatric, developmental, or emotional disabilities. It's everything we've discussed today that reaffirms that disabled people don't matter, and especially disabled people of color don't matter. Number 1, we need to know what services to signpost our BAME disabled patients to. Wherever you work or are doing placement, get to know the support available. Go on the local council website or Google the condition they had. For example, maybe deaf, Bengali, Wandsworth, and see what comes up. It might be a support group or a translated leaflet, etc. What I saw in my research is that many were frustrated that there was perhaps support groups for being Black or support groups for being autistic, for example, but rarely were those identities appreciated simultaneously. And our patients can't compartmentalize their experience, so we shouldn't compartmentalize our care. So here is just a quote from a disabled person of colour who said, "I put off asking for help for a long time because I did not realise that my GP could refer me to the support that matches my needs." Look for how you can make the environment less disabling. So if we remember back to the definition of disability earlier on in the presentation, It states, effect on ability to do normal daily activities. So part of the definition is an interaction between the person and their environment. And therefore we can preempt what our clinics need in order to accommodate for our patients, and then or make the environment less disabling. And then we can always continually listen to our patients to see where we can improve. Accurate and prompt diagnosis. Now this one is key. If you remember from the celebrity slide earlier on, Muhammad Ali was one of them. He got Parkinson's in his 40s, but what is less known is that whilst he was a child, he had dyslexia. And he said, in high school, my teachers labeled me as dumb. There was no way I was going to college. So if his school had bothered to investigate and refer his reading difficulties or disabilities to a professional team, then perhaps he would have got the interventions he needed to be able to then get those post-19 qualifications. When a patient, and especially a child patient, gets a diagnosis, they can then access or apply for the services they need, i.e. disability living allowance or education healthcare plan. This is close to my heart because my 11-year-old brother has ADHD and high functioning autism. It was in reception where a teacher that happened to be fond of him said he should go get assessed. This referral, assessment and diagnosis took 5 years. The teachers kept pushing his referral back to the pile, saying that they had referred him when they hadn't, and generally delaying in doing the paperwork. He never got the interventions he was entitled to, and on top of that suffered from outright racial and disability discrimination, and has lost 5 years of his primary education that we will never get back. And now I was on placement on my pediatric rotation in a very well-to-do borough, and was listening to this young English girl who had also been diagnosed with high functioning autism too. However, the stark difference was that what took the services 5 years to do with my brother took weeks for her. This really showed me the impact that the intersection between your race, gender, socioeconomic situation has on your education and therefore your health outcomes. Increased funding for community services. So we need more mental health crisis intervention teams so that any acute deteriorations in those with mental health disabilities, for example, are met with appropriate medical intervention rather than police intervention, which can often cause trauma and decline in mental and sometimes physical health. Available disability services and social care varies greatly from borough to borough. And as the poorest boroughs, for example, Newham and Brent, are often the most ethnically diverse. We need to find a way to make sure we level the quote unquote postcode lottery when it comes to community services. We know our disabled patients heavily rely on the MDT, i.e. the community services. And finally, if we are not aware of the problem, then we have no hope of fixing it. So we must educate ourselves on our privileges, be that disability status or race, so that we can work towards a fairer society and healthcare system where all of our patients have equal chances of positive mental and physical well-being. So thank you for listening. These are my references. If you want to learn more, then you can look at any of these references. And also here we have the Gov website, which talks about inclusive language when talking about disability. There was this report called Sick of It, done by the deaf health charity called Sign Health, which is talking about how the health service is failing deaf people. Today's Google Doodle, actually, of Dr. Harold Moody is quite interesting, and I feel like ties in with this whole series of redefining practice. And then I can also shamelessly plug my YouTube, where I do medicine, lifestyle, and education videos. And I look at the intersections between health and race. For example, I did a video on BAME, women and mental health. I could recommend that video. So that's enough from me. Thank you so much for your time. And I think we can open up the floor to any questions or comments. Thank you.
Just before we do, I just wanted to say a massive thank you, Jessica. That was a fantastic session. And just as we were going through, I was thinking, because I was on call last night, and it was really interesting because we had a patient with high functioning autism come in, and he presented very differently. So he presented with abdo pain, but he also had a background of sarcoidosis and many other conditions. And he'd been in hospital several times and got labelled with drug-seeking behaviour. And this was a black man, and came in a lot of pain. And because of his high-functioning autism, the way that he explained his condition, the way that he explained the pain that he was in, his response to being examined was very different. And so you had the discrepancy between subjective and objective pain presentation. And so no one gave him pain medications until he had a CT abdo, which revealed he had appendicitis. And it was only at that point did everyone, like, you know, raise kind of the kind of normal procedures that you would do to treat. And I think there was a lot of reflection for me on that case. And it was just really interesting listening to your talk today, having done that last night, and just reflect back on that and just think, you know, there's so much more we could have done for him earlier on, had we taken the time. Yeah, it was sad. Yeah, very sad to hear. But yeah, it was very interesting. So thank you so much for taking the time today. And we hope that you come back for more sessions, because this was fantastic. I'm sure everyone else enjoyed it as well. But everyone else, questions, if you do have any, let me not take the floor.
But no, thank you for sharing that story and the fact that it happened just last night. And for him, was it because he was a black man? Was it because he had autism? You can't say it's one or the other. It's both that affected how the care that he received. So that's very poignant. So let me just open up the chat. If there was one thing that you would want the viewers to take away from today to improve their practice, what would it be? If there was one thing, so, you know, most of my suggestions were from what I read that people with disabilities said, because I have to use this time to amplify their voices rather than any of my suggestions. And I think from what I've read, they would like to be seen. Yeah. So to see every patient, and I don't know how you get rid of your biases. You can't get rid of your biases, but what you can do is be aware of them. So I think, yeah, just make sure you see all of your patients and think about who is in front of you and how you can best adapt. We have to be adaptive because we're literally going to be seeing hundreds of people, like, you know, throughout our career. We can't, like, so for example, maybe that GP who was just looking at her computer and was being annoyed that she needed to get lip read. We can't afford to do that. We can't afford to be annoyed at our patients. Any annoyance that we have, they're going to be more scared and frightened being in this setting. Nobody really wants to be in a hospital. So know that there's a reason why they've come, to hear what they're saying and to try to be always aware of your biases. I'm not going to say get rid of them, but be aware of them. How would you recommend going about challenging bias in the workplace? So bias can take many forms. So maybe if we could be more specific, do you mean bias in terms of we see bias towards a patient, or bias amongst the colleagues, if you maybe a bit more specific? And it says, I think the process of educating clinicians and future health professionals should start earlier. Often as trainee healthcare professionals, doctors, we have to access info addressing racial inequalities through YouTube platforms such as these and Instagram. Ideally, we should learn these in medical/nursing school. This is true. You know, we get a few modules on how there's social determinants of health, but it's not really elaborated on the fact that we're learning about this, something that impacts our Black and brown patients every day, yet we don't learn about it and can make our interventions useless or not even us not to even intervene. We should definitely be learning about it. It should be mainstream rather than, yes, us having to go onto social media to learn about it. Bias against patients. So, yeah, I mean, it's hard because there can be a hierarchy and you can't, I don't know, maybe Savannah, do you want to answer that one? Do you think that there was anything, because that situation is fresh in your mind, was there anything that one could do or that you did do in that situation yesterday to challenge that bias?
You know, I think it's really difficult. I think when you reflect, it's very easy when you reflect on it to think, oh, I could have done this here. I could have said this. I think for myself, reflecting personally, I definitely need to get out of the mind frame of I'm just a medical student. So, you know, you can't say this or you can't do that. And so that definitely impacts kind of my ability to challenge things that happen. But I definitely think that there were ways that I could have done a little bit better yesterday, definitely. I mean, I was responsible for some of the history taking, and so I could have spent more time with that. I feel in that environment, I was very rushed at the time. We had loads of patients to see, and it did feel a little bit challenging to kind of redirect the conversation and adapt to the patient in front of me. At the time, it was more challenging. And I think that's the same situation the healthcare team were presented with. But there are definitely more ways that I could have challenged what happened on reflection. I think it's difficult. I think it's very much patient and moment specific.
Yes.
And it's probably a lot of it is about backing yourself and being a bit more confident in what you stand for. And that's something that I need to work on.
Yeah.
And so once that's achieved, I think you're more likely to be able to step up in those situations and say, and also clinical knowledge comes into it, because, you know, if you are aware of situations and different people and backgrounds, then you're more likely in that situation and from experience to say, hey, hold on a second, we're aware that they have high functioning autism. They've come in several times in the past for XYZ. They have this, you know, they're saying they're in pain, XYZ. Let's take a little bit more time on this. Let's address what the patient's saying, and then let's go from there.
Yeah.
If you don't have that knowledge or the experience, there's nothing. You know?
And I would also say that, so yes, it's two-pronged. So as a medical student, thankfully you do have that time. So if you see this maybe in placement, then you can go and you have the time to go take a longer history. So you could help in that way. If you ever see this happening where you feel like somebody's not really being listened to, let me try to listen, let me try and see what's going on here. And then secondly, when you're actually a professional, when you're actually a doctor, that's the challenge, isn't it? Because in high pressure environments, which the hospital often is, who gets put to the bottom of the pile? And the people who get put to the bottom of the pile, you don't even realize why, but it's because of the biases in there. So yes, taking that extra time. And also, what was I going to say? Oh, it's imperative, because at the end of the day, that person that we said yesterday, the patient that you're talking about from yesterday, he could have died. It's the appendicitis that could have ruptured and died. So even if you're not confident, don't think about it as, oh, I'm being disrespectful or anything like this, because oftentimes, if we forget about any type of bias or anything like this, sometimes our seniors can be wrong. And sometimes we can say, oh, have you considered this? So you can still say it in a very respectful but backed up way, that let's maybe consider this, and you can open the eyes of your seniors, and you can save somebody's life. So remember, we're doing this for our patients, not for ourselves. Regarding the statistics for disability, do you think that Black patients are more likely to be diagnosed with a disability because of clinical bias / lack of cultural understanding, similar to the increased mental illness incidence in Black patients? Or are the statistics accurate in saying that Black patients actually do present with disabilities more frequently? Yeah, that question does make sense. So yes, most definitely, and that's another thing as well, is that stats are unfortunately not free of bias as well. So in terms of for those that don't know, so schizophrenia is a disability. It's a lifelong mental condition that can impact the way that you do daily activities. And if a research has shown that if a Black patient comes in with, or a Black person comes in with certain symptoms, and a white person comes in with the same symptoms, the Black patient is more likely to be diagnosed with schizophrenia, is more likely to be sectioned. So that's forceful detention, like when somebody is either a threat to themselves or others, and is more likely to be put on more medication. So it's a difficult one. And that's why when I said the solution of diagnosis, I said accurate and prompt diagnosis. So that's one thing as well. Let's not have the diagnostic overshadowing. No, so yeah, accurate and prompt diagnosis. So let's try to be accurate, be aware of our biases as well. But I do think that the disability statistics are accurate because they are not only just like hospital, but their census. So it was self-reported. It was self-reported disability. Like, do you feel like you have a medical condition that impacts with your life? So I think it is accurate, but that's another thing as well. Statistics are not free of bias. It is tricky to challenge comments like that in the workplace as medical students, especially if you're new to a firm such on call with a new doctor who needs to give you a signature. Hopefully, as our clinical acumen grows, we can challenge these behaviors and advocate for our patients. Yeah, it is tricky. But even it is tricky, but sometimes there can be things that, you know, we've been told of situations where, you know, maybe you're watching in theatre and you're just the medical student, but you recognize that, oh, did we leave a tissue in there, or did, you know, or this person's blood pressure is this, or when I took the history, I found out this. As you grow as a medical student, yes, of course, your voice has more weight. And that is something about hierarchy in medicine, which can be damaging at times. We have to think of, they are trying to flatten the hierarchy. So hopefully we can still have a voice. But again, we're not doing it for our own egos or for our own signatures. I would hope that if I see a patient in dire need, that I would be able to, all doctors have their patients' needs at the forefront. Sometimes the situation at the time can make that not be the complete priority, but if you just say to them respectfully, then hopefully they'll be thankful for any new information that you bring or any suggestions that you bring. Thank you. Your answers and the presentation have been very opening. Thank you. Yeah.
Right. Thank you so much. I think that is all the questions. I mean, if there are any more questions, please do feel free to email us, or Jessica's kindly put all of her socials there. So I'm sure I'm not sure. Jessica, would you mind people contacting you?
Yeah, that's fine. And also there's a feedback form, isn't there, in the...
There is a feedback form. Sophia's kindly posted it again. So please do fill out that feedback form. It's so useful for us, but it's also really, really useful for Jessica and her portfolio. So please make sure you complete that for us. It should only take you a couple of minutes. And by doing that, you also enter yourself into a raffle. The first draw is this Sunday, and there's so many prizes that you can win. So do it for your own good and also for ours, if you don't mind. Thank you. Right, I am going to end this session. There's a few more thank yous, so I'll let them trickle through before I completely end it.
Thank you for that comment. Thank you. I'm glad everybody found it illuminating and insightful. Yeah, knowledge is power. So
very true. Right. Have a lovely evening, everybody. This will be up on the site, hopefully on, well, not, it will be up on Thursday evening, sorry. So do check on Thursday evening. If you missed anything or joined us late and you wanted to hear the beginning, there was a very interesting few slides on some statistics. If you joined us a bit later, that you should have a look back on. Very interesting. So have a good night. Bye-bye.
bye.